This is talking about red blood cell indices, the ESR test, and the PT and PTT tests that we can do. Erythrocyte indices. This is similar to the diff type things, and we look at the different sizes, shapes, and colors of the red blood cells to see how healthy they are. So you'll see these quite often on a CBC blood result when it comes back into the office. You'll be looking at this lab report, and then it'll include all of these letters, and you'll think, what the heck are these? These are important to help with anemia type patients. So this is the blood test. We've done the hemoglobin stick on the finger, and we've done the hematocrit. So we know maybe that there's something anemic going on, but we're not sure what type of anemia and how it's affecting the blood cells. Each different type of anemia can affect the blood cells the red blood cells in a different type of way. So by looking at the size, shape, content of the red blood cells, it will help us further eliminate types of anemia, so we can narrow it down and find the reason. To calculate these three, the MCV, the MCH, and the MCHC, we do need the hemoglobin and the hematocrit values. So a CBC does hemoglobin, it does hematocrit, and it does these three indices. Automation allows us to do this fairly easily, but of course there are some doctors' offices who have paid a lot of money for one of these CBC machines, but it only does that one test, and it's very expensive. Labs, of course, have much more room and much more dedicated equipment. So typically CBCs are done outside of the office in a regular lab. So what are these indices? All results are expressed as grams per deciliter. So they take a certain amount of the blood sample that you've sent to the lab, and they do tests on each of these, a deciliter of each of these. So here's the balloon analogy. You have a basket or a bowl here of water balloons, and that represents the blood sample. That's the whole blood sample. And the water inside the balloons represents the hemoglobin. Okay? So all the cells, or the balloons, are different sizes. So to get a mean volume, we have to measure all the sizes of all the balloons, and then add them up and divide by the number of balloons. When you're getting a mean number, an average number of people in the class, in classes, we compare several classes. If we wanted to get a mean age of the people in the class, we would ask everybody's age, we would add them up, and divide by the number of students in the test. Okay, so it's the same thing. We take the size of each balloon, or red blood cell, and we add them up and divide them by the number of blood cells in that bowl or in that test. This is the average or the mean mass, MCV. It's literally the volume. And that gives us the average size of a red blood cell. Okay, so MCV means volume, and it is an average size. MCH means cellular hemoglobin. Again, it's a mean. For this one, we pop the balloons and we measure the amount of fluid in each of them, and we divide by the number of balloons. Okay, so now this is volume, this is hemoglobin that we're checking, and so that means we get an average amount of hemoglobin in the body. Okay, so we pop all the balloons, take that liquid, measure it, divide by the number of balloons, and we say on average each balloon holds this much hemoglobin. MCHC, mean corpuscular hemoconcentrations. That's what the MC stands for, mean corpuscular hemoconcentration. It measures the redness of the liquid within the balloons, some light, some dark. The average of this is the intensity. Okay, so if we have 15 red and 12 dark, that's 27 balloons total, divided by 2 is 13.5. But usually there's more variations than just red and dark. I mean, there's different colours, spectrums than just 2. But here we're saying there's 2 different types. If there was 3 different types, we divide it by 3, etc. Okay, and we'd see there the colour, the concentration of heme, of blood colour, because heme is what gives blood its colour. It's not the hemoglobin, it's the part of the heme molecule that turns the blood cell That's why it looks red. So why do we do these indices? Again, it helps us understand what is wrong with an anemic person. Which part is lacking? Are we lacking in size? Are we lacking in shape? Are we lacking in hemoglobin? Are we lacking in heme? So MCH and MCV is increased if those values are increased. It could be vitamin B12 and folate. It could be blood loss. It could be hemolytic anemias, aplastic anemias, hypothyroidism, and liver disease. So many different things with those two that are increased. MCH and MCV are decreased. It could be hypochromic, which means it's got low color. Not from the red blood cells aren't very red, and they're microlytic. They're very small and they're not very red. So that could be due to iron deficiency, thalassemia, hyperthyroidism. And the MCHC increase, if it's high, could mean hereditary spherocytosis, which means that the shape of the blood cell is misshapen. Cytosis is condition of cells. Red blood cells also show up hypochromic and microcytic if the MCHC is increased. Typically the red blood cells are low in color and very small. Now we're going to move on to the ESR, the SED rate, estimated SED rate, sedimentation rate. It talks a little bit about this in the book, and it gives a small figure, 4813. But when we do it in class, you'll follow those instructions, but it doesn't give the normal values. So I'll talk about that in a second. Literally means the speed at which red blood cells fall or settle to the bottom when placed vertically in a tube which has calibrations on it. And you'll see here she's showing like 5 samples, and each one has a different rate. 2 factors influence the speed: the surface membrane condition of the red blood cell, whether it's damaged or not, and the changes in amount of fibrinogen in the plasma, and that changes with disease. If there is disease present, the speed increases. A red blood cell life is 120 days, so even if the disease has passed, it will still show in the estimated SED rate. So you could have had the flu 2 weeks ago, but the estimated SED rate reading will show that you've got some sort of inflammation going on because it's affected. It has damaged the red blood cells 2 weeks ago, and of course they still hold that damage until the end of their life, 120 days. It's a good indication that disease is imminent or passing. 2 different ways of doing the ESR. There is the Wintrobe, which is a shorter straw, which I don't have, and I tend to have the Westergren, which is more widely used. It's a longer straw. The method is exactly the same. It's just one is a shorter straw, one is a longer straw when you look at it visually. The Wintrobe, the shorter straw, needs a lavender top EDTA tube of blood or dark blue tube of blood, and the Westergren uses a sodium citrate tube of blood, which is the light blue. You can pipette it into the tube to the 0 mark, no air bubbles, and it shows you that in the figure in the book. You place the sample, you put the straw into the tube at the bottom until the blood rushes up to the top of the tube. You place the tube and the holder vertically in the rack, and you time it for 60 minutes, 1 hour, because the results are millimeters per hour. Okay, it's a distance you measure that the red blood cells have fallen from the 0, which is the top of the long straw. So 0 calibration is at the top, and then the red blood cells start to fall, and as they fall and settle, they sediment, they go down. You're counting how many millimeters it's going down. Okay, it's a distance. So you report it in millimeters per hour. And on table 48.4, it talks about the Westergren and the Wintrobe normal values. But I want you to remember the normal values for the Westergren for females. There is a slight difference between males and females. I want you to remember the females. If there's a high reading, if it drops a lot, if it drops more than 20 millimeters per hour, it means that there's been some infection, stress even, inflammation, tissue destruction, anything that damages the red blood cells, because the membrane of the red blood cell is quite sensitive to inflammation, and all the blood cells that are bashing around in there, if the white blood cells have been active recently, they release the heparin and the anticoagulants into the blood, and that starts to work on the red blood cells. So the red blood cell membranes get damaged, and through more stress or white blood cell activity. It's often increased, the damage, with menstruation, with pregnancy, lupus, malignant neoplasms, and multiple myelomas. So again, because you're in that constant state of inflammation, because your white blood cells are constantly activated against these cancers, or if you're pregnant, your white blood cells are working hard to protect the baby, multiple myelomas, lupus, even fibromyalgia, that type of thing, where you're constantly in that inflammatory response somewhere in your body, your red blood cells are being damaged. Anemia could also increase the speed depending on the severity of the anemia. Remember, if the anemia makes the red blood cells really small, they're going to fall faster too. If they're normal size, they're going to sort of elbow up against each other and not fall as fast. But if they're really tiny, they'll fall quite fast. Polycythemia and sickle cell and spherocytosis readings will be normal on an ESR. So if you have sickle cell anemia, polycythemia, or spherocytosis, your ESR reading, and nothing else going on, your ESR reading will be normal. I will give you extra credit if you give me a piece of paper to explain why each of these would show a normal ESR rate. And just explain the parts of the disease, what the disease is, and why it would show as a normal reading between 0 and 20 on an ESR. C-reactive protein, CRPs, is another thing that we can do. It's a blood test we send to the lab. We don't do that in the doctor's office. It's similar to the ESR, but it can tell doc if the treatment is working. If treatments are working, it's a faster thing to do to send it to the lab for an ESR. A C-reactive protein, again, it's not a diagnosis for a specific disease. It's only for general infection and inflammation. It shows the doctor that there's something going on, because if you have C-reactive proteins, or CRP, in your blood, it shows that there's something going on. CRP is made in the liver. It increases for infection. It's released by the liver when there's an infection present. So again, if we find CRP in the blood, this protein in the blood, more of it than we need, then we can suspect that we have an infection and inflammation. So it's similar to the ESR. It shows that there's something going on, but it doesn't really narrow it down. CRP, they say, may also be a link to vascular inflammation and heart disease. So it's used to indicate coronary artery disease, HSCRP, with a lipid profile. So if you do a cholesterol or a lipid panel and a cardiac risk assessment, if you do all of those three things together and the CRP is high, they would say that your coronary artery disease potential is high. Or it shows that you possibly have coronary artery disease. So CRP isn't conclusive on its own. It has to be done with the cardiac risk assessment and the lipid profile. CRP on its own is just saying, yep, there's something going on in your body that you're fighting. We don't know what it is. Coagulation studies is another thing that we do, especially if we're planning a surgery for a patient and they're on anticoagulants, or even if they're not on anticoagulants, we want to check their clotting times, coagulation studies. But it is definitely needed for patients who are already taking anticoagulants. Now, they could be taking anticoagulants for all sorts of reasons. So it does help provide a correct dosage level for anticoagulants to make sure we're not giving them too much. And so the PT, which is the pro time, is reported in seconds. I want you to remember the average PT in the book, again on that table, 48.4, and it is reported in seconds. The INR is the international normalized ratio for how long it should take for a blood sample to clot. Now, the INR ratios are not in here, but they are both called pro time. So when somebody says, oh, I'm going to do a pro time, they may actually be doing an INR, which is measured slightly differently, but it's doing the same thing. It's saying how fast it takes to clot. The ProTime's normal value is 11 to 15 seconds, and that's in the book. If you're on anticoagulants, 16 to 18 seconds is normal, because it takes a little bit longer to clot, but it still is under 20 seconds. Or you could have an INR, an International Normalization Ratio, reading of 2.0 to 2.6 or a little bit higher. You can't go too high on an INR, however. 5 is dangerous, which means the bleeding just won't stop. It's taking 5 minutes or more to clot. The bleeding therefore won't stop. So 5 is dangerous levels. So if they're on anticoagulants and it's getting up into the 3s and 4s, the doctor may want to say, hey, you need to cut back on the dosage for your anticoagulants because you're not stopping bleeding. But an INR of 1 means it clots too quickly, and therefore the anticoagulants are ineffective. They're not stopping the clotting. For instance, if you're taking them for DVT or for stroke, you're still getting clots in your blood fairly quickly. And so we want 2, 2.6 or a little bit higher, but not too high. Anticoagulants, people are tested regularly for their ProTime or their INR. Many things interfere with these types of medications, anticoagulants. But ProTime can also be done for liver disease because the liver produces the clotting factor. Or a clotting factor for diseases or vitamin K diseases, because all of those things, those vitamins, those clotting factor, liver disease, they all play a part in the clotting process, and if they're lacking, that could be why you're not clotting as fast. There are more automated machines to do this. Some MAs can also do this ProTime or INR tests in the office. There are little tests that you can do through a finger prick to check those, but it is more accurate to do it at a lab with an automated machine.